سعداء جدا بوجودنا مع المجموعه دي كوكبه من اليمن والمغرب وتركيا ومعرفش في جنسيات اخرى اخفلها يعني. صباح الخير جميعا. الحقيقه الموضوع الثوراسكوبيك سيرجري والاندوسكوبيك تكنيك ابتدت تاخد زخم جامد جدا جدا لاسباب كتيره. واحنا نفتكر لما كنا شباب كان اللي بيشتغل لاباروسكوبيك كوليستكتومي ونقول يا ده جراوند بريكر. At this point in time, there's a problem for those who are going into training of not seeing enough open cases. I'm saying this because we don't want the problem to be repeated after our time when we don't have people that are able to do the classic big surgeries that are going to be needed all the time. Our colleague yesterday from Britain was very clear stating that very few of the trainees there are able to do thoracotomies. This is very, very, very strange. This is in a big center in the UK. So we need to have a very balanced training for our young surgeons so that are able to keep pace with the new and the classic because they are actually complementary. We have situations where we have very large tumors, where we have mediastinal problems that need extensive dissection. And in the same time, we foresee that with the presence of the screening, the lung screening campaign for early bronchial carcinoma detection, we're going to see a lot of cases that have groundless appearance, that have subcentimetric nodules, that it will be futile to do for them a thoracotomy. Of course, the need is going to increase, but also we look at the interest, to look at the cost of disposable, and that's a problem that my good friend is going to talk about in a minute, because the cost is sometimes prohibitive, and I use the word prohibitive. So we start our first talk. Mahmoud, thank you for being here. Our colleague Mahmoud Sallam is going to speak about basic endoscopic skills for thoracic surgeons. The floor is yours. Thank you.
Good morning, everyone. I want to express our pleasure for such a gathering, and it's an honor for our department to have our dear professors and chairpersons in our event Assiut VATS 2025. I will talk today about basic endoscopic skills for thoracic surgery. Endoscopic skills for thoracic surgeon will include bronchoscopy. Here I will focus on thoracoscopic surgery. At first, I want to clarify what's different or difficult in VATS in relation to other laparoscopic surgery, endoscopic surgery. We have rib cage restricted movement, which make manipulation of the instrument is very difficult. There is no direct hand access to tissues. Camera focusing, bleeding, or lung interference can obscure the view. We have or a single lung ventilation is a must, as incomplete lung collapse will making dissection harder and making viewing the high lung is very difficult. What to be needed to be a thoracic surgeon or VATS surgeon? You should pass through very multiple simulation training with labs, virtual reality, and animal models. Eye-hand coordination must be focused on during training. Also, proper depth perception. Work under an experienced mentor for skill development. Then you should select your case with precise preoperative imaging. Also, you should have a strategic product placement and proper patient positioning. Use of articulating or angulated instrument is a must in VATS due to hard rib cage. So you have multiple angle to can reach every place in the thoracic cavity. proper lung deflation. If a single lumen is not available, you can use CO2 insufflation. Regarding instrument handle and ergonomics, you should use long, straight, or curved instrument. However, in uniportal VATS, a straight instrument will be difficult, but it's available for multi-port. You should avoid an instrument collision. Understanding how to use the articulating stapler and the curved suction device. Use minimal force. Keep movement smooth and controlled. The difference between uniportal VATS and multiportal VATS in instrument handle that all instrument enters through single incision in uniportal VATS, which lead to clashing and hand fatigue. While in multiport, you can use multiport of different angles, reducing crowding and allowing more natural hand position. In uniport, the point I mentioned, you should use curved instrument, while in multiport you can use a straight or less curved instrument. Camera and depth perception handling. We have two types of cameras, 0 degree and 30 degree camera. While using the camera, you should steady and avoid sudden movement, and before you should adjust the focus and angle. In your report, 30 degree lens will offer you a better navigation. You should move an instrument toward and away from the camera, and this is very useful to have depth perception. Use the tip of an instrument as a reference point for depth perception. Stapler handling, you should have a clear line of sight for all the staple. Use articulating staple for more angled place. Proper choice of cartridge side and lens. We use 2.5 millimeter thickness for vascular, 3.5 or 3.8 for stapling a lung tissue, and 4.1 millimeter for bronchus. Regarding dissection and tissue handling, should use blunt dissection by peanut dissector or suction tape for delicate structures. Sharp dissection scissors are cautery for fibrotic or dense tissue. Avoid direct contact of energy sealing device with the bronchus and vessels. Use automatic forceps or gentle push and hold the lung with maintenance of relaxed grip is important to avoid squeezing the tissue and hematoma development, especially when you are holding the lung tissue. Hemostasis and bleeding control should recognize the early sign of bleeding from the major vessels. You can take care of developing hematoma at the wall of the tissue or dissection. That's very dangerous, as can lead to spontaneous rupture. Effective use of suction compression and hemostatic agent. Recheck the stapler line after firing. Consider conversion to open surgery if bleeding uncontrolled. Finally, thoracoscopic surgery requires precise, smooth handling and a deep understanding of instrument mechanics. Proper practice using simulators, dry lab, and mentorship can help refine these skills for safe and efficient VATS surgery. A step-by-step guide for training in thoracoscopic instrument handling. Thank you.
He mentioned something very delicate, which is how to detect early on an impending major vessel bleed or rupture. So when you see on the arteries, especially on the arteries, starting off a small hematoma which might be intramural, you should be very cautious because just touching it may end up with a rupture, and this will cause us a problem. Would you like to tell us more about it? I'm sure you have more information than me on this, about how to detect major vessel impending rupture. Go ahead.
Yes, we use during dissection the adventitia or the fibula, as you mentioned, may have mild bleeding during dissection. Then If you continue the section, you will notice a hematoma, or the wall become from white tissue to blue tissue. At this point, you must stop and use compression for a while. Even there is no marvelous bleeding. When the sign occurs with me, I stop the maneuver at all. I may use to another part of the highland to dissect another part and leave that artery for 5 or 10 minutes.
Thank you, Dr. Mahmoud. Any question?
لا أنا عندي بس comment. The talk was about endoscopic. The talk was about endoscopic use in thoracic surgery, and you talk about the thoracoscope. Then I think we have to give a bigger attention to other types of endoscopy, like bronchoscopy, esophageoscopy. Now those tools are withdrawn from us, attract the physicians, and they have the upper hand. So I encourage everybody of our young generation, I don't know, I don't see our residents here, that they have that they have to do bronchoscopy, the rigid one, of course, who are the pioneers in the rigid bronchoscopy, the fiber optic, all the means of fiber optic, how to take a biopsy, the whoosh, the band, the mini band. Those things are ours, not the chest physicians, I mean. Sometimes before the operation, sometimes you have to do bronchoscopy to know where the tumor is, exactly where is it. And you decide to do bilobe resection, one lobe resection, pneumonectomy, you don't know. So the same for the esophageoscopy. I'm very frustrated that big centers now in Egypt, they are away from the esophageal surgery, and this is very bad. Esophageal surgery belongs to cardiothoracic surgeons, not to the general surgeons. It's ours. And everything is taken from us. Endoscopy, esophagus. Now the cardiologists have the upper hand. I will not talk about them. Thank you for...
we try to retrieve it back. We will have today as a training on bronchoscope, fiber optic and rigid, and also we will have tomorrow an esophageal surgery hands-on training with the help of Alexandria University mentors. So I think we will try to cover this.
Thank you, Dr. Mustafa, Dr. Hussein. Any question?
أنا عندي سؤال.
تفضل.
شكرا جزيلا دكتور محمود، محاضرة جميلة جدا. بس لازم حضرتك الايتم بتاع uncontrolled bleeding. What's the meaning of uncontrolled bleeding? In most of the cases انت بتشوف الدنيا كلها اتقفلت قدامك، وطبعا ما عندناش invasive arterial in most of the cases عشان نمونيتور الهيمودايناميك immediately. ف when to decide to convert from VATS to open.
طيب هو في البداية at first you can expect uncontrolled bleeding when you dissect an artery or vein, major vein or major artery. Before you dissect it, you must be prepared by every way to control the bleeding if it occurs. Okay, I learned from Dr. Hussein before I dissect the hilum, any part of the hilum, I must preparing a peanut nose beside me. And every dissection I do, I explore after it. I remove that. I look for any sign of bleeding. While I dissect an artery or major vein, I dissect any menoclinic, I stop. And I use compression. Maybe the bleeding from lung tissue I dissected hardly or underlying lymph node, also I stop. Uncontrolled, if you have ruptured branch or segmental branch, or we use compression. 10 real minute as Dr. Hussein mentioned.
محاضرة الدكتور عمرو.
يلا بينا. Thank you.